and you change from 1.5 to 1.25, Dr. Menegas asks, do you ever pull back the rotor floppy wires so that you have the floppier part in front of you so that you have less bias? Do you ever do that?
No, I don't. I
Okay.
don't. In my 30 years, I don't do that. The important aspect is in that algorithm, you must change you can change the burr, you can change the wire to remove the bias, change the biases, but it's not a good idea, I believe, to bring back the wire. You must remember that the distal segment, the floppy segment, is a 014, and then the rest of it is just a taper. The wire has a long taper. You don't want to be in a situation where your wire doesn't support your burr when it actually crosses. So algorithmic wise, can I just say to you, 1.5 go down to a 1.25. If the 1.25 doesn't cross, you may change your floppy to a rotor support, but not at angulated lesions. At curved lesions, yes, but not at angulated, because you're just going to get more biases. And then if the rotor support doesn't provide you, then you go up on the burr size to one. Remember the ballooning. I actually would tell you that the halfway rotational atherectomy is something which must keep in mind, which means that in an angulated lesion, if you are not being able to get across that angle, don't force your burr to go across an angle. If you've done the proximal part of the lesion and there's angulation after that, and the lesion goes into the angulation, just be happy to have burred the proximal part of the lesion and then go back with a balloon, and just remember to do rest of the lesion with a non-compliant balloon. Because even if you partially ablate and crack calcium, those same calcium cracks may actually help you to break the rest of the lesion, because a lesion is a continuum. These are not separate bodies. Yes, they can have separate consistencies, but your proximal rotablation before an angulation can help you crack a lesion after an angulation with just balloon itself. So that's what I call a halfway rotational atherectomy. It's not, you're not losing, you're not, how should we say? Don't need to feel guilty about the fact that you didn't go across the whole of the lesion in an angulated segment. And neither do you feel the fact that the lesion has beaten you just because you didn't cross it enough.
Right. I noticed that you used a lot of 125 burrs in pretty big vessels and proximate LADs. And I've read some chapters where they suggest that you really should be sizing the burr 0.5 to 0.6 times the reference vessel. So one question I have is, how do you decide when you should be using a smaller versus bigger burr? And I think you talked a little about the angulation that you see in the vessel itself. And the other question is, you talked about switching to rota extra support wire. When do you go up front with an extra support wire? Is it osteo lesions, or where do you actually start to go with that wire, and why?
Okay, so on the first question about, you saw the 1.2, the biggest caution around a 1.25 burr is that you should never push a 1.25 burr, because the greatest number of entrapments, burr entrapments or burr slipping through, happens with a 1.25 burr. The place where you use a 1.25 burr is tortuous anatomies. And that's why you saw that tortuous anatomy where it was downgraded from a 1.5 to a 1.25. Angulations, where you don't want to really have a large burr. And I'll also talk a bit more about that. And certainly branching points, when you come to branching, or distal small vessels. That's when you actually take a 1.25 burr. So if you saw some of those 1.25 burr, they actually fitted into that very issue of extreme calcification, tortuosity, angulations, and branching points. As regards, another point I've got to tell you is that, you remember my saying that if you don't get through a lesion after some time, you can upsize the burr. Not downsize it, you can upsize the burr if it's a straight segment, or if it's not too angulated a segment. And the reason for that is, and I've actually had instances of that, where I've gone up on the size and been able to cross it. There are two reasons for that. Firstly, of course, that you may change away the bias of the wire as you take a larger burr. But also, the more important fact, that you've got a larger ablating surface. if you see the 1.25, all it is a piece, is a rice grain type of a burr.
Well, just last two questions from the chat. Ashok, about granuloplasty, generally, do you only use 1.25 or 1.5 balloons? What's the largest balloon you will intentionally rupture with safety?
Less than 1.25 balloons, always. You're not trying to create, you're just trying to create dissections into the lesion. You're not dissecting the artery. The larger you go, the greater chances of actually traumatizing the artery and the normal segment prior to the artery. When you rupture these very small balloons, you're just creating cracks and fissures into the lesion itself and not the normal vessel wall.
And then another question, I mean, in all your cases, we saw rota, we saw IVL, we saw OPN. I didn't see a lot of cutting or scoring balloons. Are you no longer using cutting and scoring balloons, Ashok?
Oh, I should have said that on the first slide. I think they're not bad devices, but I must tell you, I don't believe that they do. Firstly, of course, they're adjunctive devices, so you're correct. But they can't replace the devices that we've talked about, the ultra high pressure balloons, the rotational atherectomy or the orbital atherectomy, and neither the IVL. So I actually have them for mild to moderate calcification. They are my tools for mild to moderate calcification, not for severely calcified lesions.
Okay.
And that, of course, while the direct comparisons of these balloons have not been done, just yesterday, Eurointervention has published the ISAR calcium study or something similar, cactus or ISAR cactus, which actually looked at a comparison of the ultra high pressure balloon with the scoring balloons in severely calcified lesions, a randomized 75 patient study with, I think, 35 patients in each group, which demonstrated the fact that cutting balloons prior to stent implantation in severely calcified lesion would give you MSAs very similar to using ultra high pressure balloons prior to stent implantation in severely calcified lesions. Though they said that the angiographic results were better in the ultra high pressure balloons, I still got to read that. That was out as of today on my Eurointervention. So I still got to read that, but I read the conclusion. So what I'm saying is numerous studies have demonstrated that they help, but they're sort of, mild to moderate calcified lesions. I don't find that as at all a useful tool in comparison to the others we talk about in severely calcified lesions.